Let's get started. Good afternoon, everyone. Welcome to today's webinar, and thank you for joining us. My name is Nalini Ranjit, and I'm an Associate Professor of Health Promotion and Behavioral Sciences at the UT Health School of Public Health in Austin. This webinar is hosted by the Michael and Susan Dell Center for Healthy Living at the UT Health School of Public Health in Austin. Our center's vision is healthy children in a healthy world. So today's topic of children's mental health is very relevant to us. Before we get started, I just wanted to make some housekeeping announcements. First, this webinar is being recorded and will be archived along with the presentation slides on our website at msdcenter.org. If you have any questions during the presentation, please enter them into the questions box. We'll have time for a Q&A at the end of the presentation. And now, I want to say a few words about our speaker. I'm very excited to introduce Dr. Laurel Williams, our speaker, who's joining us from Baylor College of Medicine in Houston. Dr. Laurel L. Williams, DO, is a professor in the Menninger Department of Psychiatry and Behavioral Sciences at Baylor College of Medicine. After graduating with a BS in psychobiology and a minor in fine arts at the University of Southern California in 1994, she obtained a DO from the University of North Texas School of Osteopathic Medicine in 1999. She then completed both her fellowship and a residency at Baylor College of Medicine in 2004, specializing in child and adolescent psychiatry. At Baylor, Dr. Williams is the training director for child and adolescent psychiatry. She has special expertise in working with youth who have had suicidal and self-injurious behaviors and pregnant and postpartum adolescents. Her honors include the Women of Excellence Award and the Norton Rose Faculty Excellence Award for Educational Leadership at the Baylor College. Both of these were awarded in 2020. Currently, Dr. Williams is serving as the medical director for the Centralized Operational Support Hub for what is known as the Texas Child Mental Health Care Consortium, shortened as TMHCC. So TMHCC is a statewide network of 12 health-related institutions providing child psychiatry and telemedicine services to support mental health needs of youth in schools. So in today's presentation, Dr. Williams is going to talk to us more about these programs. I will now hand it over to Dr. Williams to start her presentation. Dr. Williams, over to you.
Thank you so much. I really appreciate the intro. It always makes me feel a little embarrassed, but I'm here and we're here today to talk a little bit about what the state of Texas is doing. And one of the things I actually do want to say is that Texas has really put itself on the map with the consortium. There's a lot of other states around the country that are very eagerly looking into how Texas has structured these state-run programs. And I think we are really seeing ourselves as a thought leader, which is a fun place to be. We certainly learn from other states, and there's lots of programs that are going to be similar to our programs in the nation. But I do think there's some really interesting and unique things about what we're doing here in the state of Texas that I'm certainly going to hope share today. We definitely want to be done in time for us to have questions. So please make sure our team gets busy by putting questions in the chat. We're going to leave about 15-20 minutes of this hour for us to have sort of a back and forth conversation. So help is here. State-funded programs in Texas addressing youth mental health crisis. We're going to very specifically talk about two programs, but let me just go ahead and get started with the slides. So as a psychiatrist, I always joke with the slide here. I have no financial conflicts of interest. In fact, sometimes I wish I had them, but I don't. But I am riddled with other kinds of conflicts of interest. As the joke is always, psychiatrists need psychiatrists. But nonetheless, I would like to thank Dr. Tran, who is our pediatric consultation for our Child Psychiatry Access Network. She is in leadership and membership within the TPS, and also Luann Southern, who's the executive director for the consortium. So we always shorten it to not TMHCC because that's like forever. And we know that governments like their little words, but we actually just shortened it to the consortium. So whenever you hear me say consortium, that's what I'm referencing. So today we're going to talk through a couple of different pieces of information. Before we actually get to what are the state-funded programs, we need to do some level set and some grounding information about why the state felt the need to go and make these programs. And so we are going to start with a discussion of what is the percentage of young people who are currently experiencing mental health distress, particularly in the time of COVID, but there was also a wave of mental health distress that was occurring even pre-COVID. And this consortium actually was signed into law right before COVID really hit the world and Texas. Then we're going to review the allocation of psychiatric services within the state of Texas. And then I'm going to talk a little bit about the structure of the Texas Child Mental Health Care Consortium and sort of the bill itself and what it actually supplies. And then we're going to move into actually the two particular programs. And again, the reasoning for why we have these programs. So that we're going to review the AAP recommendations. We're also going to review some information and data about some other programs nationally that we've modeled ourselves after in the state of Texas. And then finally, so that you have to stay the whole hour, I'm going to finally then tell you a little bit about both the Texas Child Psychiatry Access Network as well as the Texas Child Health Access through Telemedicine. So you got to stay through all the way through to get to the goodies, potentially. I think they're good all the way. So you may or may not know this, but I do think this is really the most important slide, or one of the most important slides I'm going to share with you today. There is a tsunami of mental health distress in youth, America's youth. This has been going on now for over 10 years. We've seen steady increases in rates of both diagnosed disorders as well as just distress. This is not going away. In fact, we do think that there is going to be long-standing deficits when it comes to us getting through and out of this pandemic. We all know that this COVID is about to become endemic, but there has been a lot of stress amongst children and families across the country, across the nation. So a lot of this data I'm showing you right now is actually just what was going on with kids before the pandemic hit. And again, I'm sure as you've heard, there has definitely been a worsening for many people across the country. And we also know that worsening is unfortunately still along disparity lines. So for those individuals who have socioeconomic disparities or within minority groups, that their rates of illness and distress were high before, and they're even higher now with COVID. So the disparities have persisted. And certainly one of the things that we hope to pay attention to in the consortium is how we can be part of the solution when it comes to helping those across wherever they are and however they're needing help, that we can kind of be part of that solution. So 1 in 5 children currently have a mental health disorder that it can be diagnosed. That is extremely high rate. Think about everybody you know in your life, and if you can count up more than 5 kids, you can absolutely know that one of those young people probably has some type of mental health issue or concern that they might need assistance with. 30%, unfortunately, of teenagers will tell you that they are suffering from a sad mood that is persistent and ongoing. So not just had a bad event and feel sad for a little while, but clinically meeting sort of the criteria for having what we consider major depression. Depression and anxiety are the most common illnesses that you do find in young people, and that anxiety tends to be the most common in our elementary school age youth, and then depression starts to kind of outweigh it once you get into the adolescent time frame. But these are very common illnesses. And so this is why I want to kind of sort of level set that this is going on right now across the country, and certainly across Texas, as we can certainly understand. One of the things that we know is sort of like looking at this rain cloud is that mental health and mental wellness affect all aspects of our life. So it can rain down on you and start to affect your physical health, can affect your education, affect the relationships that you're having, as well as ultimately affect things like employment. So there is not one part of mental health or mental wellness that doesn't touch other parts of our lives. It really is, we have to think about the person as a whole and not necessarily think about them as their component parts. The other big thing that I want to pay a lot of attention to on this particular slide is that the rates of suicide have become, in of itself, an epidemic within our country. Suicide is the second leading cause of death for young people in the age group of adolescence into early adulthood. Second leading cause. Now, again, even though it's a second leading cause, it is fortunately still a rare event. But again, if I told you that cancer was the second leading cause, or cardiac issues were the second leading cause, I think that you would all agree that we might have had a different kind of response than if we say it's a mental health reason that's a second leading cause. So one of the things I always like to talk about is the issue of stigma, and how stigma itself keeps us sometimes from doing things that are going to be helpful and useful to create part of the solutions that we need to create. So most of the time when you have a young person who has suicide has been completed, it is typically a young male, and they typically are using a firearm or suffocation. It is a tendency still within our research and data that the young people who may potentially attempt with what we call less lethal means are more often young women. So they may sometimes have more actual attempts, but those who end up dying by suicide often tend to be young men, and they tend to be those who are using firearms or methods of suffocation. And a lot of things you have to understand is that suicide is not only when somebody is depressed. A fair percentage of young people, particularly the men, they often have disruptive behavior disorders. They're having issues with kind of externalizing angry outbursts, and they do the act very impulsively. And then if they have access to a lethal mean, they're able to do something before anybody can even intervene. So there's a lot of things going on for young people in the world, and this was even pre-COVID. Up to 75% of all mental health disorders that we diagnose in people today in the world occur before the age of 24. So this is an enormous percentage, and it's also a place for opportunity. Where should you best intervene? Should you best intervene when somebody finally shows up in your office at age 26, age 25, after they've had a decade of distress and challenges? Or should you try to intervene at an earlier age? So again, I've been doing psychiatry now for a bit of time, and I can tell you that I still have people who come up to me, and when they find out what I do and I say I'm a child psychiatrist, they often say, really? Like, do kids really need help? And do they really need, what they're saying is that they can't kind of wrap their head around the idea that children could have a mental health disorder. Depression happens, anxiety happens, bipolar disorder occurs, psychosis occurs, substance misuse, substance disorders occur. All of these diagnoses that adults have, young people can have as well, and 75% of the time they've already had symptoms and functional impairment prior to the age of 24. And as you can see here with the trend line at the below part of this slide, the rates of major depression have only been increasing over the last couple of years and last decade. This has been a long time trend. There's lots of people kind of researching it, trying to understand why it is. Nobody has one unifying theory that says this is the sole reason for why the rates are increasing. As with many things in health, there's multifactorial reasons for why these increases are occurring. But nonetheless, the data has been consistent year after year in this last decade. The rates are only going up. And this was, again, pre-COVID. This was before COVID was even happening. I've been talking about this. Mental health providers have been sounding the alarm. Families have been sounding the alarm that they need help. The impact, of course, with the pandemic is immeasurable, although obviously scientists are working to measure. And again, for many people, the stressors were certainly severe and potentially still impacting them, in particular because 1 million people have lost their lives in the country as a result of COVID. The number of young people who've lost their primary caregiver is inordinately high. So we're talking about young people whose lives have completely changed, impacted forever, and the issue of grief and prolonged grief and how that might change sort of your socioeconomic status within the world. All these things are going to continue to be ongoing stressors when it comes to mental health as a result of the pandemic. We have seen also, because there's not a lot of ways for people to get care or get care easily or get evidence-based care quickly, that families often turn to the emergency room. The American Hospital Association, Children's Hospital Association has, and along with the AAP, have called this a crisis. Pediatric hospitals are seeing enormous increases in the number of young people coming to the hospital in emotional mental health distress in numbers that are unprecedented. And when they come to the ER, those ERs are not equipped to help them. And one of the reasons why they're not equipped is they themselves don't have the team and the infrastructure to assist, but then they also don't have some place to send the young person, whether it's to an outpatient appointment or to an inpatient facility. You can hear every day talking to a pediatric hospital how many days or how many hours, usually days, a young person is waiting for a bed in a mental health facility. So this is a problem that was bad before the pandemic happened and has only gotten worse since the pandemic has started. And so this slide is really meant to kind of paint a really, unfortunately, bleak picture. The allocation of child and adolescent psychiatrists across the country is basically a sea of red, which is red is, and although I love red, red is not the color you want to see on this type of a slide. And when you look specifically at Texas, we are in dire need, and we have more counties than not that have no child psychiatrist in the county at all. And as you might suspect, unfortunately, when you do look to see where are there practicing psychiatrists, most of them do tend to be in a more of a populated city. And so sometimes the rural areas of our state are also very underrepresented when it comes to child psychiatry. Now, this slide is also just meant to be a placeholder for the other types of mental health providers. Child psychologists, child therapists, such as LPCs, LCSWs, are also in short supply across the state. So we're talking about a state where there's a deficit or a desert in much of the state when it comes to trying to get access to child mental health care that is hopefully by people who've been trained, have terminal degrees, and are doing evidence-based care. So this was the vision that our state had, which was a fantastic vision. I'm so excited to tell you that this is pre-COVID. Our legislatures created the Texas Child Mental Health Care Consortium as a result of these startling numbers. They wanted to try to figure out what could we do to jumpstart, additionally to things we're already doing in other parts of our state agencies, but what additionally can we do? So they created the Child Mental Health Care Consortium, which vision is all Texas children and adolescents will have the best mental health care outcome possible. And this was Senate Bill 11 in the 86th legislature. And the goal was leverage health-related institutions, HRIs, such as Baylor College of Medicine, UT-RGV, UT Houston, UT Southwestern, Texas Tech Lubbock, Texas Tech El Paso, all of the healthcare institutions that have academic psychiatry departments were going to come together across the state and work together to help solve this problem, and or not solve it completely ourselves, but be a part of the solution. And so there's actually several initiatives that are underneath the consortium. Today, though, we're only going to talk about two. And if you guys were interested enough, certainly we could come back and talk about some of the other initiatives. But today, we're only talking about the Access Network as well as the health access through telemedicine. And here's just a little example of the web page. If you were to go to our, just Google the Texas TMHCC, you will see our landing page and get to see a lot of information I'm sharing with you today. You'll find here again on our webpage. So moving on to the Texas Child Psychiatry Access Network, as you can see here, we have 12 hubs across the state of Texas, and each of those regions are covered by one of those health-related institutions, as you see listed here. We have a central number, and we have a central process so that every provider across the state will get the same service regardless of where they are in the state of Texas. So what we need to do is understand that Cpan is there for a very specific reason. Primary care providers need help. They need to, they're a superhero in so many ways, but they need help in providing mental health care. So they need to be able to task shift to promotion of mental health, to doing more of the early identification and screening, and when applicable, doing evidence-based first-line care within their own office, targeted brief interventions, so that they don't have to refer out. And then obviously when needed, doing some collaborative care when it really is a problem that's not something that they can solve within their office, then they need help kind of doing that. So Cpan is really about enriching and teaching and supporting primary care providers to do this. This is not a new idea. There's over 30 other psychiatry access networks across the country in different states. So this is actually very much in line with the AAP mental health competencies that have been asking for pediatricians, family docs have their own compatriot to this, to actually understand we need you to be upskilled, and we understand you need support in order to do that, but we need for mental health care to start to become part of just general health care and not something that's carved out and considered separate and therefore only given to a few people with this very scarce resource. So why do we say doing this in mental health and primary care? Well, again, my dad's a family physician, and he can tell you that a good percentage of the time he was helping with certainly other physical health issues per person, but very frequently he was also helping with their mental and emotional distress. The burden of mental health care of disorders is great. The physicality of mental health is interwoven together. They're not separate things. My brain is not connected to my body, right? My brain and my shoulders, like we're connected. There is obviously a treatment gap that we've just discussed. And a lot of times people trust their primary care provider, and we understand that that trust is something that we can help them build on and provide some competencies for them. And we also know that you can do this well. You can treat some of the common mental health disorders successfully in a primary care place. And a lot of primary care doctors are used to this. They can treat uncomplicated asthma. They can treat uncomplicated diabetes. They can treat uncomplicated hypertension. So they're already used to doing it with all the other systems of the body. The one system they just don't know enough about and don't get enough training in is mental health. So that's why we're going to be their, what I call the pit stop, their support team, so they can start to do these things more in their own offices. But again, a lot of the barriers are the ones I've already a little bit discussed as we've been talking. Most of the time when you survey primary care physicians after they've gotten out of their training, whether it's in primary in pediatrics or if it's in family medicine or med peds, they will tell you in my residency training, which is where you train doctors to become doctors, I didn't get that much training in this, so I don't feel comfortable. I don't really know what to do. And of course, we don't want them to do something that they shouldn't do. The other thing they'll often tell you is I actually don't have enough time. And that's very true. And that's a problem that's multifactorial. But a lot of times they have 30 plus patients that they need to see a day. And sometimes if they don't really know how to do something, it just makes it harder for them to go, you know what, I'm going to try to do this myself. So then there's insufficient time. And then again, because they didn't get all that training, they don't know the resources. They don't know how to talk to a family about how to do this. They also will tell us, and my dad would tell me this all the time, I can't get a psychiatrist to call me back on the phone and help me. So those things definitely play into it as well. And then finally, they're often not well reimbursed for extending out the care of a patient. So then that also just keeps them, one more thing that kind of keeps them from doing this. And we certainly understand that a lot of it can be about the differences between what's an illness, what's just sort of an isolated problem, and what's mental health wellness look like. And then finally, there's some things that are about psychosocial stressors, things related to diversity and barriers because of disparities that can certainly make mental health disorders worse or exacerbate them or start them. And if you can't always fix them, you can get a sense of helplessness, like what can I do? Finally. And then finally, a big one is the attitudes that we ourselves have about mental health, not only our own attitudes as physicians, but also the attitudes of families and youth that might be coming to us. So all these things become barriers. And so what we're trying to say is that what Cpan is for this sort of quadrant of integrated care. We're not sitting in the office with them, but what we can do is that we can be kind of a case manager for them on the phone, as well as we can be the team that kind of helps them think through what is the diagnosis, what could be a treatment plan, what would be a good evidence-based next step to help this person. So we're not trying to make pediatricians or family docs become psychiatrists, but we are saying that with our technical support, you can learn these skills, learn this information, and you can apply it safely and with good outcomes with your patients in your office. So the Child Psychiatry Access Network here in Texas is modeled after the Massachusetts program, which is one of the longest standing psychiatric access programs across the country. They've been going now, I did this slide like probably 2 years, so now they've been going almost 20 years. If any of you want to go look at their website, feel free, be my guest. But they've been running for a long time, and it was their groundbreaking work, excuse me, get that out, that really sort of spurred this on as a part of a national movement. As I said, now there's actually a national group of all the psychiatry access networks that we get together on a monthly basis and learn from each other, as well as we have now some outcome data that show that this program that Massachusetts kind of helped pioneer is and can be successful in providing mental health care to more kids and more youth. So the two articles I just want to touch on briefly that sort of talk about why and how this is important is that is from some of the McPack data, is that what we really discovered is that it does what we thought it did, that when a primary care doctor calls and they get this education, they're bright people, they can pick it up, they can then use that to actually help that one family and do hopefully a more thorough and accurate and better job with that one family, but then they also take that and use it for subsequent families. So again, it's a carry forward effect, and it allows them to sort of maybe start kind of where they are, maybe they don't feel comfortable at all, and over time their comfort level increases as their knowledge and competency increases, and then they might be able to take on more and more complex cases. And that is actually extremely important, because that's part of what we're doing. We're never going to turn the tide quickly enough to get more child psychiatrists, even though we're trying to crank them out more. So we're going to need this sort of solution for the foreseeable future, because of such the difference between the availability of mental health providers and the availability of primary care providers. The next thing that we want to look at with the articles is that when you ask families what they think about it, families actually rate that they trust their provider more when they know that the provider understands that there might be a gap that they need some help with, and that they reach out and ask for help. So a lot of times there's this sort of sense sometimes with doctors that I have to pretend I know everything, or I'm supposed to know everything, and if I don't, it can kind of be a barrier. And I'm worried that my families, if I tell them I don't know something, that they're not going to think I'm a competent person. But it actually increases competency and it increases trust. And if you think about why, it's like, I'm trusting you enough to know, like, I'm concerned for you. I know that Johnny needs some help, or I know that your daughter needs some help. I'm going to go talk to a trusted source from a board certified child psychiatrist. I'm going to tell them what's going on, and they're going to help us together think through what to do next. Families appreciate that, and it actually increases trust. We also know that families tend to follow through a little bit better if it's through their primary care physician, versus if the primary care physician goes and makes a referral, a lot of times the family members won't end up showing up to that appointment. Now, there's lots of reasons for why, but one of the reasons is, again, the stigma and just the uneasiness themselves of having to go tell a stranger about their problems when they kind of trust their primary care doctor a little bit more. So we want to just point out that Cpan is not experimental. What Texas is doing is, it's, on this level, is not brand new, but it is a sense of how to help do collaborative care with this type of a model. So in our Child Psychiatry Access Network in Texas, all primary care physicians in the state of Texas can be invited and are being invited as we speak to enroll in Cpan. That includes pediatricians, family docs, like I said, med peds, adolescent medicine, actually also dev peds, as well as as well as physician assistants and NPs that work within those practices. Because it's a state-funded program, there is never a cost to the primary care physician or the patient themselves for the use of the line. One of the things that we like to do is try to enroll providers in advance, and that's one of our strategies that we're currently out right now, enrolling and engaging providers across the state. But certainly a provider could call us and they've never enrolled before, and we would help them that very first day, help them, give them information that they need to help that patient, and then potentially on the back end try to help enroll them. So for in the future, when they call again, we can make that second call go even faster. So like I said, you can enroll either before or during the call. The other thing that we do, again, the call itself is educational, but we also offer a host of other educational opportunities with experts from 12 different academic medical centers. We have in Texas a veritable brain trust of extremely well researched, well practiced experts in our fields in mental health in the country here in Texas. All the providers in our state can get access to free CME activities. We have an ECHO team-based learning project that we do both fall and spring with a group of providers. We every week have a numerous CME activities, webinars, and over time we're going to build out our webpage even more to include different algorithms and different resources that they can go to. And we want, again, over time for them to see the consortium as a trusted source of expertise for mental health. The website is still not fully fully where we want it to be, but again, I encourage you to save it as a page and periodically look at it, because we certainly all the time are updating information about our various programs. So what we like to say is the Psychiatry Access Network is one phone call in three services. So when a provider calls a Cpan, they can get help with referrals and resource assistance. So maybe they really actually have a very clear understanding what the problem is, but they're having trouble finding a resource for the family, and they don't have a case manager at their office, which is, again, the margins of for primary care physicians is very razor thin. So even adding one staff member can sometimes tip them over in a way that's not financially viable. So we're saying call us. Our team will then take down what's going on with the young person, what the relevant insurance is, and then our team will go and research the question. And within one business day, we try to turn around and send back to that provider, here's a list of vetted resources that we think you should provide to that family that can help them with the problem that they're having. The other thing that our team members can do, we have licensed therapists as well as physicians. If the provider's like, well, I'm not really sure how to counsel the mom on how to help with Johnny's fears at bedtime. Okay, you got 10 minutes? Well, I'm gonna walk you through what to do to help Johnny with his bedtime routine to kind of maybe help. So we can provide immediate behavioral consultation to the primary care physician when they have a very specific question. They can also call us when the patient's not in office. So if they're like, yeah, the mom just left me a message, I'm not really sure how to respond to it, I want to ask your team, that's what our team is there for. We can help behavioral with either our therapist or a psychiatrist answering that call. And then finally, if they're really like, I'm not exactly sure what the diagnosis is, or I just got this patient coming to me and they're on 3 different medications, I have no clue what they're for, and I'm not really sure what to do, and the next time they can see a psychiatrist is 6 months, which sometimes in some areas is not a wrong number, then the psychiatrist on the Cpan team can walk that primary care physician through what could be the possible diagnosis, what additional things they might be able to do over the course of that office visit or subsequent visits, and what they might recommend from a treatment perspective. All these things can be done on the phone within 30 minutes. Our goal is, particularly if you want to speak to a child psychiatrist, you can speak to that child psychiatrist within 30 minutes of asking to call for us. When we looked at other teams across the country and the utilization of Cpan networks, we really heard from those teams that speed was essential to really help those busy primary care physicians. The other thing we tell primary care docs is like, look, if you don't want to call, you can't call us back right now because you've got 10 more patients stacked up, but you want to schedule a call to talk to us tomorrow at like 2 p.m., then fine, we'll put it in our notebook to call you tomorrow at 2. So we really are trying to help those PCPs understand we're going to work within your day as much as possible to help you help kids in the state of Texas. So like I said, the calls are answered between 8 and 5. Our first call, we answer within 5 minutes or less. If it's triaged and determined the need is a child psychiatrist, that will be within 30 minutes of that. We do collect PHI as the provider feels comfortable. If the provider does not want to give us PHI, then we say that's fine, we can still continue with the call. It's just at that point, if they call back about the same patient, we won't be able to find that record because we're not ourselves going to disclose PHI to somebody who didn't want to disclose PHI with us. So most providers do agree to provide us PHI, and that way if they call us back about the same patient, we can look back and say, oh, it looks like when you called us last time, this is what we discussed. How did that go? Okay, now that I understand how that went, now let's hear what I can tell you what to do next. Okay. So this is just a little bit of a amuse-bouche when it comes to data. We are obviously collecting a significant amount of data for our Access Network. If you go to our website, you will see this is going to be updated monthly, the dashboard. So to date, we've enrolled over 8,000 providers in the state of Texas. Providers includes, as I said, PCPs, NPs, PAs, residents, and fellows who are learning to become pediatricians and family docs. We have within those 8,000, they're in close to 1,500 different clinics. To date, we've completed over 9,579 calls with an estimated helping serve 8,601 patients. And again, we're faster than a pizza delivery is how I like to say it. We have been able to respond 98% of the time in under 6 minutes when they say they want to speak to a child psychiatrist. That's unheard of. You can't get that anywhere else. I guarantee you that it's not happening anywhere else but Texas. So this is one of the things that's really great about what the consortium has been able to put together. All right, so I'm going to shift gears. I know we've got a little bit of time before we're going to start letting us open up for questions. I guarantee you I'm almost done. We're going to move now to the Texas Child Health Access through Telemedicine, TCHATT. This is an actual direct care service. The Cpan team service was not direct care. This was us providing a consultative assistant to a primary care. One thing that is coming forward with Cpan in the future is that we will have some targeted consultations that our team will recommend to a primary care, but Cpan is largely seen as a peer-to-peer consultation. TCHATT is actually completely direct care. It is providing care to a patient and a family after parental consent has been obtained to actually do telehealth care for young people in the state of Texas. And the reason for why we do this is very simple. Now, COVID expanded this and moved this at lightning speed. Remember, this is all pre-COVID. We had planned to do telehealth because we understand that I had families that were coming 3 hours both ways to come see me for an hour appointment. That's just so disruptive in somebody's life. If we could have the schools partner with us so that we have a confidential, secure place at the school for the child to go and have a secure telehealth appointment with their legal guardian and with our HRI team during the day, it's so less disruptive. They can get their health care, go back to their next class. And so this is really the reason for why TCHATT was created, was we wanted to be timely, we wanted to use evidence-informed practices, and it was patient and family-centered, and that we were going to partner with both schools, other care teams in the area, along with PCPs as well. So this is actually urgent short-term care. TCHATT is not meant to be a long-term service, but it is meant to be a service that potentially, if maybe nobody's had a service before and people are noticing it, the school is noticing it, the parent is noticing it, the parent agrees to the referral, then we can get in within 2 weeks and see this young person for an assessment. Again, this is unheard of across the state, and it's just a phenomenal. We now have other states across the country that are wanting us to come and speak to what we've been able to build at the consortium level. This is not an up-to-date map at all, so I would highly encourage you, if you're interested, to go back to our website, go onto the TCHATT page, and you will see an actual up-to-date map of all the schools that are currently participating. We at this point have about 35, almost 40% of the total population of students that could be served in the state of Texas. Now, we have never said, the consortium has never said that we're going to be able to cover every school. Part of that reason is that it's a relationship with the school and the families and the schools. They have to say they want the service. And occasionally we do have ISDs who decline and say, look, we're really good. We don't think that we need to have a specific relationship with the consortium. We have other ways that we help kids kind of find resources. So the consortium was never about trying to cover everybody, but it is still, I think, a great success story to say that of the young people in the state of Texas, about 35% of them currently could, if their families wished for it, could get access to TCHATT services. As I said, we are partnering with regional TEA educational support teams to kind of figure out which schools to try to reach, which ISDs to try to reach. The teams within our group consist of psychologists, licensed therapists, as well as child psychiatrists. We're using a data management system that covers both Cpan and TCHATT, because we also imagine over time there's going to be crossover of patients that are seen in TCHATT, but then they could eventually be helped with Cpan and vice versa. So our data capture system has a system that can actually engage families, engage parents, engage school personnel if parents give permission, and then finally engage PCPs if we need to sort of circle back and get them linked into Cpan. So this is really about truly providing a comprehensive service that provides an intervention that is short term, but maybe helps that family either solve a problem, because sometimes we're able to solve it with our short-term care, or get them connected to what's going on with their child and then help them find a resource after the service is over. Our goals in TCHATT are always to coordinate and collaborate on the ground. We never want to be a duplicate service. That would be a fail on our end. We understand that there are other teams out there doing great work, and we want to make sure we're all working together and to go in the same direction than working at cross purposes. And so as you can see here, this is a very preliminary data point. We have a lot of data is being collected. In the next couple of months, we're going to be putting out a lot more of that data to a variety of stakeholders. But as you can see here, we've had steady enrollment and growth in the number of young people that have been served or been enrolled, I should say, as of the end of April 2022. And this all happened during the middle of a global pandemic. And you can understand the sort of amount of work it took for all of our teams across the state and the HRIs, as well as all the school districts themselves. There were so many things happening to those schools, so overwhelming for their personnel. They were scared for their own families. They were trying to figure out what to do with doing online school. And so I just commend everybody in this effort, both for Cpan and TCHATT. All the hard work our teams have done has really been amazing. And I think we're doing something just truly blessed that we're able to do it. I'm so excited. So I think I actually ended almost exactly on time. Oh, wow. So we did want to leave about 20 minutes for questions. So I'm going to pause here. Thank you. And go to the last page that I want to make sure you have. We do have a variety of different social media presences. Encourage you to consider joining the one that makes the most sense to you. We often send out information that's just about mental health issues. We also send out information about other CME or webinars, or other activities that people can get linked into and do. So I do think that we would certainly love for you to kind of follow our progress and follow what we're doing on the consortium. And once again, thank you for your time and attention, and hopefully you're able to eat lunch at the same time, because I know that it is lunchtime.
Thank you, Dr. Williams. What a great talk, and it's so exciting to know that we're doing all this in Texas. I'm particularly excited about all the data that you're collecting, because I think it can multiply the effects of what you're doing. We'll go ahead and take some time for questions now. Feel free to type them into the chat box. Meanwhile, a few have come in already, so I'm going to read those out to you, Dr. Williams.
Sure.
There's several questions, actually. I think people seem to be really concerned about the prevalence of mental health disorders across the state, and the fact that the numbers have been rising even pre-COVID.
Correct.
So here's a couple of questions that I'm going to just paraphrase those questions. So one suggestion is that, is it more diagnosis? Is that why we're seeing more mental health issues in kids? And there's another one that just asked, why are the numbers just getting worse across different SES groups? I mean, it's clear that COVID exacerbated them, but it's what's happening before COVID to make the numbers rise?
So I do think, again, there's definitely different people doing research in this arena, and there's no one definitive answer as to why. Certainly there has been a question of, well, is it just that we're diagnosing more people and that they don't, maybe we didn't recognize in the past that people had these disorders, or maybe there's something about the criteria has changed and either lowered the bar so that more people are labeled with the disorder. So I think that in large, I've been doing this for a while. I've watched a couple of what we call our manuals for diagnosis. Our DSM has changed from 3.3 to 5. The diagnoses that we have within within mental health, there has been some changes in the autism spectrum diagnosis disorder, which I think caused a fair amount of people to ask that question. But by and large, the actual symptomatology of mental health disorders has not changed. What's changed possibly is that there maybe is less stigma, so people are more willing to bring up that they think that they're struggling, that they think that there's a problem. And that certainly is, I think, a favorable thing, that more and more people are talking about mental health, mental wellness, as well as mental distress and mental illness. And we're non-stigmatizing it. Andy Keller, one of my friends, likes to talk about how his mom, who's a generation older than the two of us, that everybody used to whisper cancer. Like nobody wanted to say cancer out loud because it just felt like if you said it, you were going to catch it and you're going to get cancer too. Well, we know that's not how cancer works. So mental health is kind of the same thing. We're still kind of in that whispering phase where people say it, but they don't really say it. And we're really just working hard all the time to get more people. So part of the answer may be yes, more people are feeling comfortable to share they're having a problem and they're bringing it to people's attention so that we know. A lot of this data also will come from the surveys that they do of youth. There's national surveys where they go out and randomly sample young people and ask them how they're doing. And so this is directly coming from young people themselves, not from a physician diagnosing them, where they're saying, I am in more distress. Not that they're saying themselves personally, but when you look from year to year, the kids that are saying that they're in stress are higher. I think the other thing that people often talk about is technology. The jury is still really out, but I do think that there is some evidence that there are definitely, particularly for vulnerable people, that technology actually can sort of either exacerbate or potentially cause a distress that is emotional distress. So we're obviously, our world is moving at such a rapid pace when it comes to access to various things. So I do think that that's probably a part of it. But I would, again, there's no one study that says this is exactly the reason for why. I think all of the things that you know that cause distress and stress, so all the ACEs, the issues with racism and issues with bias, all these things we're understanding over and time again how they impact negatively not just the body, but also the mind.
Yeah, that's a great answer. I completely agree that technology, and it's such a double-sided sword. On the
Yes.
one hand, it can cause mental distress because you're losing out on exercise, losing out on sleep. But on the other hand, people's awareness increases because they understand that, okay, maybe I have a mental health condition when they see other people on social media talking about it.
Correct.
Yeah, great response. There's a couple of questions about Cpan and TCHATT specifically.
Sure.
So one question is, does Cpan have a text message access system?
So we currently have a phone line, and again, the phone line is picked up really quick. So we turn that around really quickly. We're in the midst of doing a pilot project through the ARPA monies that all the states were able to get, the American Rescue Plan Act dollars. The state has appropriated some of those ARPA dollars for Texas to the consortium. One of the initiatives we're doing is a pilot of a texting option for PCPs to Texas. I have to tell you right now, it's not actually, most of them are still preferring to pick up the phone. It is in the pilot stage, so we've not made it be statewide yet because we want to understand how it really works. But we're not actually seeing it run like gangbusters just yet. So time will tell whether or not they prefer that. We're also going to be researching having what we call a web portal so that they could go in and put in that at maybe any time of the night, but it could be, we would pick it up the next day, work on it, get back to them. They could see the information back and forth in a secure HIPAA compliant portal, which is the data management system we use. So we're researching whether or not that's something else that primary care doctors would pick up and use. But right now, they seem to be, at least in this pilot phase, preferring to still call versus text.
That's really interesting.
Mm-hmm.
Another Cpan TCHATT question was, are private schools eligible to participate in TCHATT?
So private schools are not, but charter schools can. So sometimes we have to kind of, on a case-by-case basis, talk it over with my boss, Luann, to make sure that we're following the legislature's aim when it comes to providing access to services.
Okay. Another question, which actually was something I was thinking about as well. When your child gets done seeing the TCHATT therapist or the school, is that a long-term arrangement? Can they continue to see that therapist? Or is it like a one and done kind of thing?
So the TCHATT services, what we call TCHATT standard is an assessment. And again, that assessment could include only a therapist. It can include a therapist and a psychiatrist, or only a psychiatrist. Part of it, there is a little bit of variability with that depending on the different teams across the state. But by and large, if the family is really saying, like, I think what my child needs is a therapist, that's who they see. If they say, I think what my child needs is a psychiatrist, that's what they need. So by and large, we actually talk with the family to determine what is the best professional to meet with your child and with you. And then we can have up to 5 visits with the young person. Now, because we're providing clinical care, and from our perspective, we can't just suddenly stop somebody's care. If we determine that they're going to need ongoing care beyond our TCHATT team, we can have an opportunity on a case-by-case basis to see a young person for a little bit longer while we work with that family to find the next step, the next resource. So the short answer is no. Usually you're not going to see the same person, but the longer answer is we're not just going to stop somebody's care in a way that's going to be detrimental, but we will transition them if needed and applicable.
Okay, that's really good to know.
Mm-hmm.
There was one question. What do you think needs to happen from the top down, so as a statewide initiative which already exists in the form of this consortium, or from the ground up in homes and schools to help fill children's mental and behavioral health needs and
Well,
the
I do
shortage
think,
of
yeah.
professionals.
So the top-down approach, this is personal opinions here. I've been in mental health for a while. I don't think they're easily solved because a lot of it has to do with how our healthcare system is designed. And I guess you could say we've got the system we've asked for. So if we really want to have a different system, I do think that we might really need to rethink it. There's lots of different pieces to it. So I could pick you one piece and then you could give me a lot of research about why that one idea is a bad one. So it's really, there's layers of sort of challenges, I would think, at the top line level. There's workforce problems. We don't have enough people coming into therapists, psychologists, psychiatrists. So there's not enough people to do the work. When they get to do the work, they often don't get reimbursed very well, which often means that a lot of times they don't take insurance, which most families need and want. Or if they do, they end up having to see patients in very quick turnaround because the reimbursement rates do not model what other types of healthcare are providing. They also have a lot of limits, like, oh, I can only see somebody 3 times, 4 times, but if they had other kind of a health illness, I could see them as long as they need. So there's lots of layers to why the top-down can be problematic and why you can't probably just say one solution is going to fix it. The bottom up, I do think that part of it is really healthy living. So a lot of the work that you do, I was really excited when I was reading your bio, is really about how to make environments that we live in more conducive to growth and health and wellness. So there's actually some data around just having green spaces reduces the amount of ADHD, helping young people get engaged with reading early helps them not be stressed at school, so then they're not stressed. So I think there's a lot of different ways that you can, as a society, we can, as a parent, as a person at a school, as a person in our community, sort of develop an environment that kind of help us see as having a society that is equitable and helps people kind of manage life in such a way. There are one of the programs that we're going to be doing with the ARPA funding, that extra federal dollars that are coming in, is we're doing a program across the state. 10 of our 12 HRIs are participating in this. We're going to partner with local school districts, with families in those school districts, so everybody's going to get on board with it. It's not going to come in there solo and do something, but we're going to provide an evidence-based education of sort of a health class, a 5-session health class that's taught by a facilitated teacher that comes from us, so that school's not having to provide it. And it's called YAM, Youth Awareness Mental Health. And what YAM does is it teaches young people in the early middle school grades and up how to understand mental health, mental wellness, how to help themselves be healthier from a mental health perspective, and how to reach out and get help if you need it. And so it's 5 classes, and what they found with this project and this program is that teaching young people this information reduces the rates of depression, reduces the rates of suicide attempts. So we have to empower young people. The other thing we need to do is empower young people and families that have had mental health challenges with peer and family support. There's lots of people out there. You don't always need a psychiatrist. You don't always need a therapist. Sometimes you need a PCP who knows and can provide some counsel. Sometimes you might be able to get that through your church or your synagogue, or other sort of places of worship. There's lots of different people that can all be part of the solution, and that's how we're going to get better. It's, again, as a child psychiatrist, I would be happy to not have children come to see me. That's fine. But what I want is for all children to be healthy and to be well. And we can do that all together. It's not a one size, one person solution.
Yeah, there's so much to do. There's a couple of other questions which I know it's getting a little bit late, but seems
Sure.
like these questions are important and relevant. So one question was, does Cpan TCHATT take into consideration insurance or ability to pay for the child or family? How are these services funded?
So the service is funded through general revenue through the state. So I'm talking to you today because of that funding. So the PCP is never charged to call Cpan. The Cpan team will take information from the PCP. What insurance does that family have? And if they have insurance, or if they don't, then our team will go and research solutions, referrals that might help that person based on the situation that that family has. So if the family has an insurance, we'll know what kind it is. We'll go and try to find a resource or referral that will help them based on their insurance, or if they don't have insurance, what particular avenues can we recommend for them to refer. So Cpan itself is never charging the family, never charging the provider. If they actually go get a resource, then yes, of course, they're going to pay that. They're going to do whatever transaction needs to happen to go and work with that resource. For TCHATT, again, we do not charge the families for coming to a TCHATT service. So the TCHATT services are funded through the state. So to see a child psychiatrist, a therapist, or psychologist in TCHATT, we are not billing for our services. We are being paid by the state to provide those services. Certainly if a young person might need a lab or might need a diagnostic test or might need perhaps a medication, at that point the family is responsible for paying those things. But the actual visits themselves in TCHATT, they are not being asked to pay for. So it is regardless of your ability to pay. It is primarily if you, if the school personnel says, hey, I'm worried about your child, and the mom or dad says, yes, me too, and the school says, hey, this program might help you, would you like me to make a referral for you? And the family says, yes, please make the referral, then the referral is made. If they talk to the parent and the parent's like, no, I don't really want to do a telehealth thing, I don't want that, then we never hear about that because at that point it's none of our beeswax. So we only hear from families that have heard about us, have agreed that they want to potentially pursue this service, and then we get the referral.
And then does TCHATT coordinate all those resources and make the therapist available for the child? That's fantastic.
For TCHATT, yes. So if you're going to be seen in TCHATT, we will reach out to the family. We will schedule the appointments. Now, some of the appointments we're doing on campus, and like I said, that confidential space during the middle of COVID when everything was shut down. All of the appointments were happening in families' homes. We now have a hybrid. So sometimes a family is going to be seen at the school. The child goes into a confidential room. The parent hopefully comes themselves. If the parent can't come, they're on the phone so that we're all having the appointment together. If the school does not have space or the family does not want to have their mental health care at the school for any reason, then we could still potentially have them go to their own house like they do in the middle of the day. They take the child out like they do for a dentist appointment or anything else. They come pick the child up, go to their house, have the appointment, come back. But that's still way quicker than driving 3 hours to see me. So even if it's still a little bit more logistical challenge, if families would like to do it at their home versus doing it on the school campus, they can. Or for those campuses that don't have a confidential space, then we also still provided telehealth via the home. It's just that we always need to have the parent participating and present.
Okay. There was one last question, which I think is related to what you said. Is there access to Spanish-speaking providers, or can that be arranged?
Oh, we will provide services in whichever language a person prefers and is most comfortable in. So whether it's Spanish, Mandarin, Urdu, whichever language the family needs to have the conversation in, we will have a certified translator help participate. Obviously, some of our providers across the state are bilingual with Spanish, but I want to just emphasize that regardless of the language, the TCHATT service is available to everybody.
Okay. There is one more question. I think the answer for that can go on another hour. As a K-12 educator, what can we do to support our children in the classroom that we see are struggling with the stress of re-engaging after COVID?
I think that that's a great question. We actually do have activities that we do, teaching activities to school personnel. So for TCHATT, just like with Cpan, we do a lot of activities with the school. They sometimes want us to come talk to teachers, talk to parents. Again, sometimes we've talked to students. We're doing that sort of very specific YAM program as well. But what you can do as a support is teach about emotions and how it's okay to have them, and everybody has them. And within reason, share what your emotions are, even if they're maybe in the fussy realm versus in the happy realm, and make it an obvious thing that you respect that people have emotions and that they have different moods, and that you want them to respect others as well, so that they can feel comfortable to share with you. One of the ways that we help people get better is knowing what's going on. And if people feel uncomfortable or afraid to share, we don't get an opportunity to know. So I think that the teachers themselves can use that piece to really help, and just acknowledge that this stuff is tough. Like, you're having a tough time too as a teacher, and think about that when you think about somebody who is a young person that maybe doesn't have the same experiences that you've had, don't know how to manage their emotions yet. So it's okay to say, we always say that the way you get through this a lot of times is sharing at a sort of a developmentally appropriate manner. How are you doing? And I think honestly schools are doing a bang up job. I am very impressed with the school that my young person goes to. And I think that a lot of Texas educators, all Texas educators, doing a phenomenal job. This has just been bananas, right? Bananas.
Okay, that's a great note to end the webinar, and it's too bad. Well, thank you everyone for attending today's webinar. We really appreciate you being here, and Dr. Williams, that was fantastic.
Great.
Remember this Remember this webinar will be archived on our website at msdcenter.org. Thank you again for joining us today, and we'll see you next time. Bye-bye.
Take care, y'all.